Okay. Good morning and welcome to the July 7th, 2020 Stanislaus County Board of Supervisors special meeting. I do have a few announcements before we get started, but first I will open the meeting. For the few announcements, we do have Supervisor Tom Berryhill participating via telephone today. Good morning, Supervisor Berryhill.
Good morning.
Good morning. This meeting is open to the public, so we have reopened the chambers for members of the public to attend. In order to provide for social distancing, however, the chamber's audience seating capacity is limited to approximately 30 people. Consistent with guidance issued by the California Department of Public Health, face coverings are available to all members of the audience and participants in the meeting. Under the guidance, there are exemptions for their use, and therefore the public may see some of us not using them at certain times during the meeting, for example, when we aren't able to be socially distanced. Public comments will be limited to 3 to 5 minutes at the discretion of the chair, myself, depending on the number of speakers. The option for verbal comments by telephone, as we have been doing over the last few months, is no longer offered since in-person attendance is allowed. So again, we want to clarify for board meetings from here on out, members of the public who wish to make verbal comments related during either the public comment period or on a specific item are welcome to attend in person and provide your comments from the dais. However, we will still allow public comments submitted by email before the start of the meeting to be part of the public record, and they will be distributed to the board members for our consideration during the meeting, as has been done today. We have received several comments by email. If you would like to still send your comment for our review, please email that comment to the clerk of the board at cobsupport@stancounty.com and list public comment period or the specific agenda item number that you would like to address in the subject line of the email. Finally, we wanted to remind everyone how they can watch the meeting if they aren't here in person. You can observe a live stream of the meeting at http://www.stancounty.com/sclive/. That live stream link is also provided on the agenda, which can be found on the Board of Supervisors website at stancounty.com. In addition, board meetings are broadcast live on local cable television stations. That is Channel 7 in Modesto, Channel 96 in Oakdale, and on Channel 19 for the rest of the county. And with that, I actually don't see an agenda before me, but I assume we will start with the Pledge of Allegiance. Yes. And do we have an invocation this morning? Okay, we will start with the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
And the first item on our agenda today is public comment period. As I mentioned, we have received several public comments by email, so we will review those and address those after the meeting. Do we have any additional public comments received before we move on in the agenda via email, County Clerk?
We do not.
Okay, and are there any members of the public wishing to provide public comment at this time? Seeing none, we will move on to item 3.1, discussion item, approval to receive an update from the Public Health Officer on the COVID-19 emergency and authorize the Chief Executive Officer to sign certifications for receipt of funds pursuant to the California Budget Act of 2020. CEO Jody Hayes.
Thank you very much, Chairwoman Olson and members of the board. We appreciate the opportunity to schedule this additional meeting of the Board of Supervisors. As you're aware, we've had a lot of developments emerge over the last week to 2 weeks in response to the COVID-19 emergency, and we felt it was important for us to bring the board together even though we were originally not scheduled to meet this week. So thank you very much for everyone being here today and for members of the public who are watching from home. I'll be kicking off the presentation this morning and then invite along Mary Ann Lilly from our Health Services Agency. She's our director, as well as Dr. Julie Wei-Champagne, our Public Health Officer, to help support some of the other items that we're going to discuss today. As we always do, I'd like to start by just reviewing our latest data here in Stanislaus County, and I also want to bring to your attention some of the new components of our county dashboard. So as of today, we're reporting 2,760 cases in Stanislaus County. You're going to learn a little bit later in this presentation that number needs to be adjusted, and that we have quite a few cases that have not flowed through the system onto our dashboard today. That'll actually be one of our main topics of discussion today, but that is what we're currently reporting. And I want to go ahead and go to the next slide, our neighborhood reporting slide. You see this is information we've reported in the past, and Ryan, if we could go to one more. We have had a couple of deaths since our last reporting as well, and I'm looking for our hospitalization slide. There you go. Hospitalizations, this is a new component of our dashboard, and this allows all of us to see the demographics of those that are currently hospitalized for care for COVID-19. And what is important here is you can see the growth in hospitalizations and where the actual individual age categories. We have two different charts off to the bottom right here, and they reflect broadly two different age groups. On the right, you have individuals that fall into more of the elderly category, folks who are over 70 years of age, and everyone on the left, which are those gradients of green, are those folks who are under age 70. This has been important because I think there's been a lot of reporting that our deaths have been largely in the older age category, as well as a recognition that they are the most vulnerable in the community. And what this chart shows is that the driving force behind hospitalizations in Stanislaus County, at least, has been that younger age population. And even as you look today, and I'm looking at the numbers where we're at today, you can see that if you just take everyone up to age 50, I think we're at 24, 30, almost a third of the population in the hospital would be individuals below the age of 50. And I think there's a lot of perception in the community that anyone in that younger age category would not be as impacted to the point where they would need hospitalization. And I am going to be talking about our conversations with hospital administrators that I've had over the last week and all the way up until yesterday afternoon. And I will tell you that in many cases they have reported to me that they have some patients with severe illnesses that are in those younger age categories. They are not the driver of most of the deaths that have occurred, and we recognize that, but it does occur, and it's not just our community, but elsewhere they're experiencing this. And unfortunately here in Stanislaus County, we've got some folks on the younger end of the age scale that have become very, very ill in our community. Go ahead, Ryan. This is our testing dashboard. I do want to point out that one of the things in our dashboard, I will tell you, is one of the best in the state in terms of the volume of information that's available. I've looked around through multiple counties, and we have a team of folks that if we ever find anything another county's doing better, we tell them we want that, and within pretty short order they deliver it for us. So what you're seeing is the culmination of 3 months of us giving them ideas and the community asking us for additional information, and this is what's reported out. With that said, there are still things that we need to improve on in the dashboard, and the testing site is one of those specific areas. Our average days of turnaround time, we need to put up some historical data there, because what it would demonstrate is that as of late, in many instances, the average turnaround time has increased due to bottleneck capacity at state labs and so forth. But right now we're showing 2.1 days, and your experience will be different depending upon whether you're tested in a hospital setting versus whether you're tested at one of the community clinics or elsewhere. However, 2.1 time is, I think it's important, I always like to point out, that's the average since we've been tracking this data. However, we do want to get some historical context on there so that the public can see whether those turnaround times are increasing, and we don't have that available on the public-facing website right now. Go ahead, Ryan. Okay, this is another new component of the website, and it's a lot of information to take in, but it's very important for us, particularly as it relates to what's open and available in Stanislaus County for businesses. So we have taken the 6 variance criteria that the state of California is monitoring, and you have heard many comments about the state is monitoring local counties and their performance. I think another batch of counties were just added to that monitoring list yesterday. The list continues to grow. It is most of California except for rural Northern California at this point. There are a couple of exceptions to that, but we are not alone in being in the monitoring group at this point. It is the vast majority of the population of California is under monitoring standards. So we felt it was important to be able to show the community exactly what the criteria are for monitoring, and you can go on the dashboard at any time. It's updated at least once per day, and you can see how we're performing based on the thresholds that the state has put forward. So it is a little difficult to read, but essentially all of those gray areas are where the state will monitor, and if we can keep our numbers outside of the gray area, then that means that we're performing better. And the easiest way to know is you can just look at the dashboard toggle right there, and you can get a sense of are we in a red or a green status. So we really appreciate the team putting that together for us. This is essentially the type of data that we're monitoring in response or in trying to lead this emergency response, and we're trying to provide the community the same types of data that we're looking at as well. Thank you, Ryan. Okay, so the major topic of discussion in terms of data in our community is around hospitalizations. And we have spent quite a few conversations with local hospital administrators as well as their leadership and their leadership teams that oversee the licensed care of individuals in Stanislaus County. And from our perspective, if you had to have one metric that would tell you what the severity of impact is in COVID-19 in Stanislaus County, this hospitalization chart would be that metric. We know that not all local patients are Stanislaus County residents, so I've heard that quite a bit, and I just want to make sure everyone knows the vast majority of patients in our hospital come from Stanislaus County. The last time we looked at that data, it was at least 75% of the patients that you're seeing in local hospitals are our local residents. But we are a part of large healthcare systems that have other affiliates as well. So while we may take in patients from other rural areas to our south or to our east, we are actually shipping some patients outside of our county as well to other hospitals. So I am aware of our three largest affiliated hospital systems. They have all shipped patients out to other locations, even within the last week, in some cases. Some of it's for specialty reasons and so forth, but on occasion it is purely for capacity reasons as well. So I think it's important for everyone to understand that when we look at hospitalizations, it is largely reflective of what's happening in Stanislaus, and although we do have patients who come in from elsewhere, we also ship patients out as well. So this chart reflects our confirmed positive and suspected cases. So even when not confirmed, hospital staff must treat suspected individuals with the same level of protection and protocols. So yes, we focus on what are the confirmed number of individuals in the hospital. That is at its core the most important issue. But you can see in the most recent week or two that we've had a significant increase in suspected patients in the hospital. So those are individuals that are being tested. Their test results haven't come back yet, and it's very important that the hospital treat them as if they are COVID positive. So this chart will show you the last 60 days, and our dashboard has been focused on 14 days. And at this point, it can almost be perceived as misleading if you're not looking at that longer period of time. So I wanted to make sure that we took a stroll back to when some of our policy decisions had been made previously, and you can see what the impacts of those have been in the community from that period of time. So for most of the period of time prior to about a week after the Memorial Day holiday, week or two after that, our county was below 50 cases. And almost every single day, we actually bottomed out at one day where we only had 22 cases in the community, and 8 of those I think were suspected. We were down to 14 confirmed COVID cases in Stanislaus County. And this was literally right about that time of the Memorial Day weekend, shortly thereafter. And You'll recall that the state of California had provided us the opportunity to open up additional businesses. Stanislaus County, as well as most counties granted those variance criteria, opened up pretty much all of the available businesses. Now, not every county did, so I have to acknowledge that. So there's some reflection there for us, but we essentially opened up at that time most of what was available, or I guess all of what was available. Later on, the county or the state did provide additional opportunity to open up personal services, which would include nail salons, massages, tattoos, and so forth. However, we did not take action to implement those additional increases, as we had already seen increased hospitalization and community spread. And we'll talk more about that before we're done today. So when you look at this particular chart, we essentially got ourselves down to about 14 people confirmed with COVID positive just after Memorial Day. 2 weeks later, we had 40 cases in Stanislaus County in the hospital. 2 more weeks, we had 100 cases of confirmed, and 10 more days later, we had 154 confirmed cases. So I think it's important to recognize how fast this turnaround occurred. These numbers developed very, very quickly. It's the reason that we're scheduling this special meeting and not waiting another week to have this community discussion. The main concern in talking to hospital executives and their leadership team, it's not the concern with their ability to manage what they currently have in the hospitals today. They actually all expressed with confidence to me that they can manage and support our community in today's scenario. And I would never suggest that any of our hospitals would indicate that they couldn't support the community even in a much worse scenario. But what they have all described consistently is that the trend that we are on today, and that consistent blue, dark blue line that you see going up, is not sustainable in our community. And it will reach the point where it exceeds the capacity of our hospital systems to effectively and safely care for all of the healthcare needs of Stanislaus County residents. And what happens in that scenario is we then rely on regional resources. We then rely on the implementation of measures and processes that could have impacts on the daily delivery of healthcare services in Stanislaus County. So there are types of services that could get delayed for residents. There's a whole host of corresponding impacts if our hospital systems are overflooded with individuals in COVID-19. So I want to go back for a moment, Ryan, if you could, to the hospitalization chart. So we're going to go backwards, and there you go, right there. So this is the chart that we have been using up until now to help us understand exactly what I just said and whether or not it's a concern or not a concern. Do we have hospitalization capacity? Should we be concerned, and so forth? And I think there are a few key takeaways over the last week that I want to acknowledge that are very important here. The first is on the top right chart there, you can see available beds and in-use beds. And these are based on licensed beds in Stanislaus County. And I think there's a presumption from the community, and a very fair presumption, that hospitals can work up to and support licensed bed capacity on any given day at a moment's notice, if that's what it takes. And that is not accurate, that hospitals take time in order to staff up to that type of capacity. And what we've also learned very clearly, and this isn't news to many of us in the organization. I think for those individuals on our team that work with healthcare frequently, they know this stuff, and it's been contemplated in our prior conversations. But on any given day, it's very difficult to understand just how many staff have been employed by each hospital to support their licensed beds. That number is not reported through this process. The California Department of Public Health gathers this information on a daily basis from every hospital in the state of California, and then reports it on a state website, and then we grab data from it and we put it onto our dashboard. So in that effect, it's consistent and it's accurate. However, what it's not telling you is the depth of information related to our readiness to support the type of increase that we just looked at on that prior page. And particularly, we're getting hit with a couple of scenarios here. The first is that the month of July is one of the slowest months for hospitals generally. They would describe to you that they have very low census in the month of July. They typically do not have as many staff planned to work. Hospitals do not just rely upon full-time year-round staff. They have staff that are more seasonal, that come and go in the hospital system, and those staff would not have been programmed to be there during this particular time. At the same time, they have had a significant increase in non-COVID hospitalizations. So and it's a theory, there's no scientific study right now to tell us this is what's happening, but the theory is that so many individuals have deferred their hospital care over the last 3 to 4 months that are now coming into the hospital system because they've waited too long, maybe they've deferred preventative care, and now they're at the point where they need acute hospital care services, and they are coming into the hospital. So what I've learned from our largest hospital systems is they will tell you that their numbers are up, and that includes non-COVID numbers. They're up. In addition to that, they now have what I think you can fairly call at this point a surge in COVID patients in our hospital. They're seeing the surge both of non-COVID patients and COVID patients. The culmination of those two things occurring in the middle of summer when they are typically staffed for the least amount of service is what's creating the strain on our hospital systems here in Stanislaus County. Every hospital is working very hard to bring on whatever staffing is necessary for them to be able to utilize the breadth of their physical bed space. So they will tell you that they are putting together their surge plans and they are working through the process, and they're bringing more and more resources into our community every single day. Those things cannot happen in just a 24-hour period. In some cases, it may take, up to a week in order for them to mobilize the level of resources that are necessary. So as early as this morning, I was hearing reports about hospitals that are having to take measures to move patients around the system in order to be able to safely manage the patient load here in Stanislaus County. I think the takeaway from that long explanation I just provided to you is this chart at the top right is important to us. It tells us where we're at in relation to licensed beds. It does not tell us at this moment in time how stressful it is for the hospital system to be operating at the numbers that you're seeing. And the prevailing feedback we get from our local hospitals is that they are running very tight. That appears to be the term that they use most frequently. The next thing I want to refer to is our ICU bed daily count there. And you can see that we have in use and available, very similar to the hospital bed daily count. And a key takeaway on this chart is that starting in late April, the California Department of Public Health had added neonatal and what we call NICU beds. These are pediatric type or neonatal beds for ICU. And it's a specialty function and obviously is not set up to service an adult in an ICU environment, largely, or mostly speaking. So what you're seeing here is, although on this chart I think we're reflecting about 58 available beds, if I'm reading it correctly, in our ICU bed count, almost all of those beds would be pediatric or NICU available beds today, or close to that. So what we're actually hearing from the hospitals are ICU beds available for the adult population are very, very thin in our community right now. I also want to, share that the hospitals have, expressed that that's not unusual for them. They go through busy times of the year, and it's not that, being stretched thin today is any worse than it has been for them in other peak periods of time, particularly when they hit flu season. In other times, we've had bad flu seasons in Stanislaus County and in our state, and they've probably been in these types of similar situations that haven't required us to come together as a community and talk about it, because they manage it. They do surge planning. They do a lot of things that help us behind the scenes where us as everyday members of the community may not even recognize that you've been moved from one floor to the hospital to the next, and you just know that you're getting good service. But what's happening behind the scenes is they're adjusting. They even add ICU wings. A hospital can convert an entire wing to an ICU process in pretty short order. They have most of the physical tools necessary to do that. It's the staffing and people power is what it really takes to do some of those things. But it happens. It happens in our community, and it goes without, broad reporting. And every now and then you'll hear an article about how it was a big flu season, but not this level of detail. What's different and unique here is that our hospital systems have brought forward their concern that if these trends do not change in the next 2 to 3 weeks, and particularly concerned with what level of spread may have occurred in the community over the July 4th weekend, then they will be in a very difficult situation, is how they characterize it. So it's one thing to surge and to support this process over a 2 or 3 week period. It's another to be in that situation over 2 to 3 months, and what that does to your staffing resources at the same time that other hospital systems and other locations are dealing with the same exact scenario. So I want to go to our modeling here, and so we're going to toggle out of the presentation, and we're going to look at the some of the specific reports that we have available. And you can go ahead and go down there, Ryan. So if you go out on our county website, you'll see our healthcare modeling here. And this is essentially what the conversation boils down to us, is what can we expect to occur in the next couple of months in Stanislaus County, and what do we think our available resources are for COVID-19. So on this chart, you'll see our total licensed hospital beds, and you can see that even in what we characterize as our worser case situation here, we may not hit that particular benchmark. However, everyone recognizes that our hospitals already have a ton of work to do, and they cannot just treat COVID patients. So somewhere in there we have to, estimate what is the available hospital capacity for COVID patients. On this chart, we're reflecting it at about almost 500. However, I can tell you many hospitals would say that might be too generous, that the number should be less than that. But roughly speaking, you may expect that could be the capacity, and that our data suggests that that's most likely what it is for COVID positive patients in Stanislaus County. And then you have these different variations here, and the variations are just built on statistical modeling for how well we social distance in Stanislaus County. And there's been a lot of data that's come in now over the last 4 months. Dr. V is going to talk about this later, because we learned a lot more about this than we knew 6 months ago, 4 months ago, and it's all being built into statistical modeling. And so it then generates different scenarios here. And our problem as a community right now is that up until about 3 weeks ago, every time we looked at one of these health models, we were outperforming it, and outperforming it in a good way, which meant our hospitalization numbers were on a better track than almost every model we looked at. And that gave us confidence. And you can go back to the 60 days chart there, and you can see where that confidence comes from. But Ryan, if you go down where we look at this in further detail, that trend is entirely reversed. In the last 2 to 3 weeks, our models have consistently shown that actual hospitalizations in Stanislaus County are tracking or underperforming almost every single version of our statistical modeling. So that's great concern to us, and it leads us to this conversation, and it provides the backdrop for the kinds of policy decisions that need to be made. I do want to acknowledge kind of upfront in this presentation today that most policy decisions have already been made, because the governor of California made a lot of decisions in the last week that handed down requirements to local governments to shutter businesses. I think this conversation and the data is very important for our community to understand in this community, in Stanislaus County, what is happening, what does our best projections suggest for us, and that we all have a responsibility to do what we can to try to slow the spread of COVID-19, not because we're going to eliminate it. We are not in our community, but we are going to try to support our local hospital systems so that if any one of us or our loved ones wind up in those hospital systems, they have every bit of care that they deserve. And that's essentially what this comes down to. So Ryan, we're going to go back to the presentation. And I am going to pick up towards the end here, but for now I want to turn it over to our Health Services Agency, Mary Ann Lilly, to describe what's happening with investigation and contact tracing capacity.
Thank you, Jody. Good morning. Mary Ann Lilly from the Health Services Agency. And I'm going to share some information with you about the positive cases and the reporting of those and the process sort of behind those cases and what we're doing with the community. And the one thing I wanted to start with is to tell you that the positive cases that we're reporting are real, but there are more than what are on our dashboard, and some of that has to do with timing and process. So I'm going to walk through with you, and this is about the positive cases, not about what Jody was just speaking about with hospitalizations. That's a different data source, CDPH, a bed poll that we get real time. So those numbers are the real-time hospital numbers. What I'm talking about are the positive test numbers. So I've mentioned before that we get the test result numbers through a database from the state. That's that CalReady database. And the various labs report the results into this state database. They first go into a staging before they go into an active, and there's a process that goes on. The CalReady database it's a person system, so it's a unique person, and we have to go through all those results to deduplicate, find the duplicates. We need to determine whether it's a unique person that's already in the CalReady database for this or for a different communicable disease that was tracked. So there's some scrubbing, if you will, so that we don't over-report the same person, right? There's also clearance testing that goes on. So there may be more than one test for the same person. We only want to count it once. So there's a process that goes on then to move those positive tests into the active CalReady database. If for those that are watching the state database on the positive numbers, it's the total number of those active cases. When we start working on, we'll contact the individual. We need to confirm where they are. Is this their accurate address? We gather some demographic information. It's after that process is done, because there is some more cleaning that goes on, and we're getting that information that feeds various points in our dashboard. It's at that point that we report the positive numbers daily. So the numbers that we're reporting are real, and the numbers that the state are reporting are real, but there's a timing difference in process. And so there are still more positive cases that we have not yet reported because we've not gone through that process. I mentioned the verification that we do. The investigation goes into much more depth, where we're interviewing the individual, where we're finding out more about that will help us for contact tracing. We find out we try to learn about where they have been, what if this is a work site situation, their maybe the source of transmission. That helps us determine some mitigation activities that we will need to do. We find out if they have certain needs in terms of isolation. Might be a need for food, and then there's coordination that goes on with the care and shelter. And then there's a handoff to a team that reaches out and does the contact tracing. All of that takes quite a bit of time and manpower, and we are behind. And I want to make sure that everybody is aware of that, and we're being transparent about it. Over the coming, the other thing I want to mention is that the numbers were pretty close before, because we didn't have a lot of volume, and so we could go through that process pretty quickly. But over the course of the last 2 weeks, the positive numbers are increasing at such a rapid pace that we're having difficulty keeping up with that, and that's why we have accumulated this backlog and this difference between the state number of positive cases and our reported positive cases. We're making various process changes. We continue to add staff. Last week, we were able to bring on 20 of the state contact tracers. We've brought on about 20, combination of part-time and full-time individuals to help with various parts of this, but we still have a backlog. We're working on some process changes. We're in consultation with Dr. Weishampayan, looking at, well, all of the questions that we're asking. What are the most important? What's the most important information for us to collect, and from whom, for the greatest harm reduction in the community and the most effective way to try to contain the spread. So we're making various changes to try to close the backlog, but the community will see our numbers increasing dramatically as we work through this process in the coming week to 2 weeks. And we'll be looking at our dashboard in terms of how to report. Perhaps we'll be reporting the state number, and there'll be some changes as we go through the rest of that investigation and verification process. So I just wanted to give you an update on where we are and be transparent that the numbers are high, they're increasing, and they're greater than what we're reporting right now because of this process. With that, I think
I think we can pause there just to make sure we ask any questions on that particular topic, because I know that I've had some individual conversations with some board members over the last couple of days to try to describe what Mary Ann's describing here, and I know there's lots of concern. So, any questions?
Supervisor Chiesa.
Hi. The scrubbing process, though, it's a quality assurance is really what we're doing to make sure that we correctly identify. But it's still very high. The numbers that we get, very few people fall out, right, from the scrubbing, the duplicate process, the getting.
Okay. In terms of verifying whether they're in our county residents or another, it mattered a lot more when our numbers are really small and you'd find one. Now our numbers are big, so you're right. It's not. We know, say, in the congregate setting where we're doing retesting, we know there's clearance testing, so that there is duplication, that we don't want to over-report the same individual. So there is some that fall out during that staging to active process.
Does that make the state's number too high also? Because they get notified of a positive test and it goes up on their website before we've done the scrubbing, right?
The state is reporting, some of the scrubbing's already been done because of the staging to the active. Some of those have fallen out already, and the state's reporting the active CalReady numbers. We're reporting after we do the verification process. So there is a level of scrubbing that's already happening between the staging and the active.
And that scrubbing,
Does that
for
answer?
clarification, happens at the local level, right, by us.
Good question.
Yeah.
That has been completely a local responsibility. As of this week, because of the backlog, the state is providing some of their own manpower to help through that staging to active to help us catch up for a couple of weeks.
So we have layers of quality control. There's an initial layer, a secondary layer, and then on. And the numbers that the state is reporting have at least one layer of quality control in there. Mm-hmm. And up until recently, we were purely responsible for that. The state has taken over some of that.
Temporarily, correct. Correct.
Could I add one thing onto that? Sorry. That's a little loud. So the system, unless it's changed, parses by zip code, and zip codes cross county lines. They're not geocoded. So there is significant non-county that gets allocated to you. It goes to the county with the most population in that zip code. So, I mean, they set that up in the beginning if it's this zip code. So you do get significant out of county, and other counties do transfer to you.
And I think it's because now we're getting, I know our highest reported day was 140, but we're obviously in the hundreds now. We've had days that were in the hundreds of reporting. So much like the hospital staffing, it's the same thing for the county, that it's nearly impossible to find 10 extra people tomorrow, and it's a continual building of the process. I think it's important, and I know that yesterday we got some of this information out, but there might be 500, 1,000 or more people that are positive in the community that haven't been reported out yet. And I think that it's important because the psychology here is that things weren't that bad. We can talk about it all day long on social media and here, and there's not a lot of people reporting on it, but things are not out of control, but they're growing at a pace that no one is comfortable with inside the medical community. And this would be just another thing to add to that, especially in a naysayer that we're not reporting correctly or we're not doing something correct. That's not the case. It's about staffing. It's about quality assurance. So I appreciate the information.
Question for me, I just have a hard time understanding why the state and the county would have different criteria for the numbers we report and when. Because they're just, the only outcome that seems to come from that is confusing the public, right? So it feels like there needs to be a way for the state and the county, or counties, if this is something that's happening across the state, to reconcile the differences between what is reported and when. Because otherwise, as Supervisor Chiesa just suggested, people aren't going to trust any numbers anymore reported by anyone. So is there a way to reconcile what's taking place?
Well, I think we may want to move to reporting the active CalReady numbers before we go through the verification and investigation process. We get a lot of the demographic information from that CalReady database. There are some additional elements that we get from the verification and investigation process, for instance, and some of the contact tracing, the clusters, the outbreaks, the source of transmission. So some of what Jody mentioned, that we deliver a lot of information on that database to the community. There are some elements that come after we get through some of that process. And so maybe we'll begin to report that active CalReady number. Most of the database elements, we would have that demographic information, but there'll be a lag in the, say, the outbreak and the source of transmission. In
the breakdown of that larger number.
It mattered a
That
lot
makes
more
sense.
when we had 100 cases then it's, the significance is less now in terms of the percentage breakout in those various data elements.
Okay.
So I think that will take care of some of that confusion, and just know that there are some that will lag that we learn as we go through that process, and so that may be some days out. I think it's really important that, that the community knows that there are more than what has been reported. They're going to see a backlog. They're going to see these daily increases really going up. They're real. I think it is in excess of 200 a day, really, that are coming in, and that's reflective of the state's data numbers.
Okay, thank you. I know it's an incredibly complicated process, so I appreciate you guys reviewing how we can continually improve it, because I agree with you. I think more information to the public is better, and I think this county has done a phenomenal job in breaking down numbers and reporting all those numbers on the dashboard. So if I would hate to have to give up any of that, it would seem to make more sense to move in the direction that it sounds like you guys are considering, where we report the initial number and then maybe the breakdowns of that number are a little bit further behind. But thank you for reviewing all that and explaining it to us.
Can I ask one more question?
Yes, Supervisor Chiesa.
Does this skew the positivity number if we lump sum it? Because reporting it out every day obviously will give us a true positivity on a running 7-day or 3-day or whatever we want to use. But does this change that?
The
Yeah,
positivity
sure.
rate?
The positivity rate.
Usually when we pull that, we pull it by the day it's reported to us, so it should not skew it. We sometimes do it by the date the lab is drawn, or so the sample is collected.
Okay.
So we have ways to make that not matter.
Okay.
Yeah.
Supervisor DiMartini.
I just had a question about the value of the contact tracing. So as I understand that people get infected with this virus, have it for maybe 2 weeks before the symptoms show up. So, if that's the case, how can you be certain at all of where that person contracted that virus if it was 2 weeks before? I can't even remember where I was 2 weeks ago. I just wondered, how the value of that tracing with that kind of delay in the symptoms showing up. So I was just curious about that, because I know we're spending a ton of money on it, and I'd like to be sure that we're getting some value out of it.
That's a very good question, and we've been considering that as well in trying to figure out how to do more streamlining and what is going to be the most effective for the community. And we will limit some of that contact tracing going forward, so that we're looking at those where we think there's the greatest impact to harm reduction, workplace, congregate living, but some of, for instance, household contacts. We're giving the information to the first positive case, including information about any household contacts, so we won't be making contact with each individual. So you're right. As we work through this process, and with some of those delays, we really need to look at where can we make the biggest difference.
Yeah, I'd also wondered if the numbers that are increasing or have any relationship of just the increase in the amount of testing that we're doing. That's how we find out how many people are positive, but if we did more testing, the numbers show more, or less testing, the number is less, because I don't know where else you're getting these numbers outside of the testing.
You are so right. The testing capacity is increased, and it is fully subscribed. There's a longer time now when you want to get a test to when you can actually get that scheduled. So there is a lot more testing going on, but the testing rate, the positivity rate, how many of those are positive, what percentage are positive compared to negative? It's showing that there is an increase of infection in the community.
In my understanding of this, that some people are hardly affected by this virus at all, or some people wind up on ventilators, so I'm not sure why. What I've heard is that some of the younger people, which are stronger and all, they show hardly any symptoms at all. Sometimes they maybe even none, and then some people are really debilitated by that. And I just wondered why that's the case.
I think I should leave that to you.
Yeah.
I mean, I don't know. I don't know anything about this. I've had the flu a number of times in my life, and I've never really been concerned about it. And sometimes I've been sick for over a week, but sometimes it's just one day, but I've never considered it life-threatening.
So I don't think anyone knows why older people tend to have more symptoms and younger people tend to be a bit more asymptomatic. I don't think that's known. We do know which receptor this virus binds to, and there is some talk about maybe kids have less of it than older people, so they have less virus infecting them and they can clear it more easily without becoming symptomatic. There is really no, nobody knows yet. And I'm going to cover a little bit that, yes, and just move forward in what I'm talking about. So I will be talking a little bit about what we know and what we still need to learn.
Okay, yeah, because I have some more questions on that line, but I'll wait until you.
Okay.
Yeah, thank you, Marianne.
Thank you, Marion. So we're going to transition to this next part, and in introducing Dr. V's comments, I want to acknowledge that I have seen a lot of reports of confusion around what do health officials believe or not believe. And people get attacked sometimes, and they say, well, on one day you said this, and on another day you said this. And I just want to be upfront and telling you what I've learned, that when you have a new disease like this that enters the world space, the prevailing opinions and recommendations around how to deal with it are going to change, and they're going to change over time as studies are done and as science continues to inform us on how this thing is progressing in the community. So I asked Dr. V today to do her usual presentation with some of the data elements that she's concerned about, but to also provide to us in reflection over the last several months, what have we learned? What do we know that's different today than maybe we were even thinking 90 days ago, that if you pulled up one of these presentations from 3 months ago, we would have been saying things that you wouldn't say today. So with that, I'll go ahead and turn it over to Dr. V, and I think she's going to cover several of those topics that you bring forward, Supervisor DiMartino.
Yes, thank you. So I'm going to start with what we've learned. So I was actually kind of excited, well, that's a sad word to use, but that today is actually the 6-month anniversary of when they announced in China what this virus was that was causing this disease, right? I brought up that so many times. It was January 7th. So here we are, July 7. We have 6 whole months of knowledge about this new virus that we didn't know anything about before. And I have to say that everything we thought back in January and February, I think was wrong. So we have had a lot of knowledge, and we still have a whole bunch more to learn. But there are many things we thought to be true that just aren't true. So as we look at how it's spread, and I keep talking about droplets, and sometimes I forget that not everybody knows what I mean when I talk about droplets. So I thought I'd stop a minute and explain why that's so important. So when we talk in medicine, we talk about the way airborne diseases spread, and we usually talk about 2 different ways. We talk about droplets and we talk about aerosols. And you want it to be a droplet disease, so this is good news, because aerosols are very, very difficult. So I saw, well, it's actually the health officer, San Mateo, wrote an article about this, and his analogy was an aerosol is more like the smell of baking in your home, right? It's like smell. It just kind of permeates everything. It hangs in the air for a long time. Someone could walk in an hour later and know you baked bread or something like that, or you did something with cinnamon. That's an aerosol, and it's really, really difficult because people can cough and create these aerosols in the air of, like, say, tuberculosis or measles. Measles is the classic one we talk about, and someone can walk in the room an hour later and get it. Luckily, this is very rarely reported to do that. It can happen, and it's happened a couple times, but it's primarily droplets. And the wonderful thing about droplets is that droplets, when you excrete, droplets when you spit, droplets come out of your mouth, emit, I guess, most of them, they're all different sizes. So they're going to fall down to the ground because they're bigger than the tiny, tiny little aerosol particles that stay in the air a lot longer. So most of them are going to drop to the ground quickly. And so that's why that 6-foot distance is so important, because at 3 feet, a lot of them fall to the ground. By 6 feet, a lot more of them fall to the ground. And I'm going to show a little graphic on that. So it's really important to remember that this is primarily a droplet spread disease. That's what it looks like through all the data we have. Like they said, I was on a CDC call yesterday. We have over 11 million cases in the world, and we have like 2 good reports of aerosol transmission. So it can happen. It can be rare. It can transmit to a lot of people if it hangs in the room for a while, but it's not what we see. Again, we put a lot of effort on cleaning and surfaces, and it doesn't seem to be a major part of transmission. So washing your hands is still very important, but cleaning is still always important, but it's not, if you're going to put your effort somewhere, it's going to be on that droplet prevention. So I'm going to talk a little bit more about a few things. The other thing about droplets and aerosols both is that the more air there is, the larger the room, being outdoors, having some sort of breeze clears the room, both droplets and aerosols. So I've spent a lot of time talking to businesses and everyone about their ventilation system. Maximize your ventilation system. That's one of the ways to do it. If you're worried about anything, just make sure your ventilation system is maximized. The most outdoor air, don't recirculate the air, turn it on the most air exchanges. There's a lot of things you can do to improve the ventilation. Dilute it out, move the air around, and you're less likely to get infected with these. This is also why we talk about the 6 feet away. This is also why we talk about the face covering. I have to tell you, the face covering is just amazing for stopping droplets. We knew nothing about face coverings at the beginning, cloth face coverings. There was zero data when we started talking about, well, maybe we should look at this. They really, there's a lot of data coming out now about how many droplets they actually do prevent from coming out, and maybe even a little protection from you being able to inhale them in. We've mostly messaged that it stops the droplets, but there looks like some protection from you inhaling them as well. So really, really easy things, not necessarily comfortable, but really easy things we can do to slow down the spread, stop it with you. This is not a flu pandemic. We were hoping this was going to be a flu pandemic, and it was going to come in waves like every other flu pandemic. You can go back 10 pandemics in the last 250 years or something like that, and every one of them came in waves. This isn't doing that. I think we can throw the waves out the window. I think we can throw the fall wave out the window. This isn't waves. I heard an analogy that this is like a wildfire. It is just going to keep spreading. It is here, and it's smoldering, and as soon as you bring people together who are non-immune, who are the fuel, it just flares up, and it's going to continue to do that until we have enough immunity to start stopping that spread. So think of it more as a fire, not as a pandemic with waves, because that is just not so far the way it's acting. It's also not like the other coronaviruses. So, in the beginning, we looked at flu pandemics and we looked at the coronaviruses we knew, and we tried to make decisions on whether it was going to look like that. And it just isn't really acting. So one of the things early on we talked about was asymptomatic spread. So I skipped a little ahead. It's two things, they're seasonal. So first, we have seasonal coronaviruses. We have 4 coronaviruses that cause about 30% of the common cold. They're seasonal. This one does not appear to have a lot of seasonal variation. Maybe it does, and that bodes very ill for the winter if this is the lightest time with the least amount of spread. But the other thing is asymptomatic, and that's so important. I remember early on Tony Fauci standing up there and saying asymptomatic spread has never driven any pandemic. Okay, I can tell you right now, asymptomatic spread is driving this pandemic. We are estimating as much as 40% of spread is from people without symptoms, and that is a problem. And that is another reason the face coverings are so important. I don't know if I'm going to get symptoms tomorrow. I don't know if I'm going to get symptoms in 2 days, so I need to keep my droplets away from everyone around me. So there's a lot of things that we've learned. We still have a whole bunch more to learn, and we're trying, but it's actually amazing how much we've learned in 6 months. There'd be no other pathogen like this, and if you talk to scientists, it's actually fascinating. I showed this, which I think might have been just last week, maybe it was the week before, I don't remember anymore. But this is droplets. So your cough is 6 feet. When you're just talking and exhaling, you see the 4.5 feet. So I always say, 3 feet's good, 6 feet's better, 9 feet's better. I mean, the further apart you can get, the better you're going to be. Okay, cover your coughs and cover your sneezes and stay 6 feet away. It's just, it works, and it'll keep people safe. So I was looking for a number to try to tell you how protected you are by distance, and I couldn't really find a lot. But there was this study that just recently came out of Lancet, I think it was June 20, and they looked at this analysis of 172 studies over 16 countries. But the red box I put in there with 1 meter or 3 feet, your odds ratio, if standing close to them is 1, if you stayed at least 1 meter away, which is about 39 inches, your odds was 0.18. So that's protection, right? Your odds of 1 to 1 means it's the same. You were protected massively by staying at least 1 meter apart. And then as the distance was lengthened, you could see that you could increase your protection quite a bit more. And then, of course, the face covering use could get a larger reduction in there, and then stronger with stronger masks. So the further apart you are, it's been shown, the less likely you are to get infected, and further is better always. Outdoor is better than indoor. There's another study I saw that being outdoor and exposure, you were 19 times more likely indoor to get infected than you were outdoor. So outdoor is so much better, which is why some of the actions that have been taken lately to move everything outside, and it dilutes the air moves. It's really all about sharing air, just as it is with all respiratory diseases. Okay, so that's kind of a summary of what we know, what we didn't know in the beginning. There's still some things we don't know, but let's talk about where we are now, because it's really not a good place. So here's our graph by specimen collection date, and I'm using that instead of symptom onset because that has less of a delay in time. So you can see we've had a large increase. We're kind of dwarfing anything we had before, which we thought were pretty big increases. You can see one day of specimen collection, we had over 120 positives, so it's really, really increased lately. The numbers coming in. Our test positivity has really gone up. We're like around 13% positive. Remember when we were down in the 2s and 3s? Yeah, no more. We're at 13%. So not only are we testing more people, but out of every 100, instead of 3 being positive, we're now getting 13 positive. So it's been a huge increase in positivity as well. Oh, as you look at fevers, and this is our syndromic surveillance that I kind of show, and you can see here is fever, and you can see the increase in emergency department visits for people with fever, up to 65 a day towards the end of June. So we're really seeing increase. I'm just showing you we're seeing increase in all our signals and all the things we're looking at. Cough, we were nice and down at the end of May, beginning of June, and you can see we're really increasing again towards the end of June. So people are coming in with fever and cough quite a bit more than they were just a couple weeks ago. So I've had a few questions about death rate. Has the proportion who have died decreased? And so here we're looking at an ongoing percentage of death by date. And what you can see, the large hump in the middle was kind of when we had the large skilled nursing facility outbreak, and it really did increase our proportion who had died quite high. You can see we're running just a little over 1.5% of detected cases right now. So I get asked if it's decreasing now because we're seeing it more in younger people. Yeah, but a large outbreak in a congregate facility with elderly would probably bring us up again. And so it really depends on where we have the infection. So I'm going to move on to testing and capacity, because this is becoming an issue. So first I thought I'd start with testing, and I know we had talked about giving positive tests by zip code. So this is the rate. The reason we like to do rate and standardize it by population, so you can compare zip code to zip code. So you can see there's some zip code 95351 that approaches 9 per thousand so far. There's some 8s, and there's some 6s, 5s, 4s, so they're a little bit across the board. But another question I've been asked, and we can share these slides so people can look at them more in depth, and if we can put them on the website if you guys want, because I just got these yesterday. How are we doing for testing? So we looked at the rate of negative tests as well, and honestly it's pretty even across zip codes. 95319, I know I looked these up. The smaller zip codes, just a few tests make more of a difference. So you'll see large increases or decreases in smaller zip codes. But still, between 40 and 80 per thousand negative tests per zip code is pretty standard here. I mean, 40 to 80 is a pretty big range, but it's pretty well represented across various zip codes. The data aren't complete, they aren't necessarily clean because we don't clean the negative data. It just comes into CalReady. We don't do anything with it. So I can't even tell you these are all Stanislaus County residents, but these are the reports we've received and have been allocated to our county. This is the turnaround time. So it was really high in when we first started testing, right? It had to go to CDC and shipping and everything, and it took 5 days at least. Our average turnaround time came down as laboratory capacity expanded. But we're seeing a surge in not just California, but many states. The vast majority of our labs go to big national laboratories like Quest and LabCorp, and they are just inundated with labs. And you can see our turnaround time is really increasing the last couple weeks just with this huge demand. So even with incomplete data, we're at a minimum of 3.5 days for around the week of June 23. So this is a problem. We're starting to get reports of specimens not being able to be run because they're running out of reagents. So we've solved the swab problem. We're now running into reagents and lab capacity problems again. And it will be solved, but this isn't helpful when we're trying to do contact investigation and, identify people who are infected and clear people for work and all sorts of things, because if the average is 3.5, there's a lot that are rapid tests in hospitals will be done in one day, and then there's a lot that are taken a whole week. So everyone's going to have to be patient, because this is just not something in our control here. These are primarily large national labs, and hopefully they will be able to ramp up their testing capacity as long as the reagents hold out. So it's all great news today.
Dr. V, if you don't
Yes.
mind, I do want to add a comment for members of the public watching this presentation. Hospitals do have many testing options within their facilities and so forth, but we have had some recent reports of individuals just going to hospital emergency rooms solely for the purpose of testing, asymptomatic testing. And that is not a good development for our community for many reasons. There's a tremendous cost to the community, to the individual to do that as well. But hospital emergency rooms are not the place for asymptomatic testing. I just want to make sure the community hears that clearly.
Yeah, and right now, unless it's a congregate setting or public health is recommending, we are strongly recommending against asymptomatic testing, except as directed by public health, because there just aren't enough supplies. We need to keep it for the symptomatic testing and the places where we need to know asymptomatic, such as congregate living and other places like that. So in the coming weeks, we have concerns, as you said. So here's another estimate, and the state put out this new model called LEMA, which is great. They introduced it last Friday on a conference call, and it's great because I don't remember what it stands for, but the L is local. So it's based on local data, and it's much better rather than models that are built on like statewide for large numbers and things like that. And as you can see, we're tracking right along that yellow line, and if you follow that out with our current state, it is not a good picture, and we really need to turn this curve and flatten our curve and do all those things that we need to do that I've tried to explain the reasonings behind so far. So we are going to continue to closely monitor our hospital capacity and assist them in any way we can. We are also going to continue, I think more importantly, messaging to the public. We have to change our behavior to change this. Because of the asymptomatic spread, we can contact trace and do everything we can to get back to Supervisor DeMartini's point. We cannot possibly do it enough by itself to slow spread. First of all, we can't possibly do it enough with all the cases we got in. According to the state's website, which, sadly is the best right at this second, they're reporting that we had over 2,000 cases in the last 2 weeks. That's why we're behind. We have a total of 3,000 something cases, and over 2,000 of them came in the last 2 weeks. That is not someplace we want to be, and that is not someplace we can be. So we need to really get the public to understand what they have to do to, again, flatten this curve and bring these hospitalizations under control, bring the cases under control. It can't be done through contact tracing. We can work to stop outbreaks, which is why we're prioritizing outbreaks and congregate settings. We can work in all those places where it's spread and we're seeing spread. But all the general spread, we're just not going to be able to do. People are going to have to take the actions they need. It's really going to be in their hands. Some of what we're doing in our prioritizes is we're putting out guidelines for everyone who's positive. There has been a blanket order for everyone in Stanislaus County since April 7th that if you test positive, you are required to be in isolation, and if you know you're a contact, you're required to be in quarantine. That has been on our website since April 7th. We worked to update it this weekend for a simple update that they had changed the time of exposure to 15 minutes from 10. So we updated the guidance that goes with that. We updated the order on July 5. And they were being translated into Spanish yesterday, and I haven't seen that they're posted, but hopefully by today they will be posted. But people need to take responsibility for following this order and informing their contacts that they're positive, because we are not going to be able to get to that for general day-to-day activities. We are going to focus on the congregate settings and really stopping the spread in the places where it can spread the fastest and the most. And then I think Mary Ann had talked some about all the staff we've added. We've continued to add a lot of staff to help, and we're going to continue to work on that as we move through these days. The state has really stepped up and helped us to the tune of, like I said, she said, 20 contact tracers. They're importing our data from staging to CalReady, and they're doing a lot of data entry for our negative labs that are faxed to us, because we get a whole bunch of faxes of labs that aren't necessarily directly reporting into CalReady. So those are some issues that that we are working through. So here's a picture I took yesterday of our emergency operations, not our emergency operations, our case investigation contact tracing. Verification is actually behind that wall in the back, so you can't actually see those people. But there is a whole bunch of people working on this. I hope you can see that and understand that this is, it's large. It's larger because not everybody's here. We're running 7 days a week. We're talking about adding on an evening shift. We're doing what we can to get this done. Some of the processes that we've improved are putting the verification and the investigation together and getting rid of some of those elements. So, for example, so you understand, one of the questions from the case report form is contact with animals. We got a pretty good idea that we're not getting this from animals in this country, so we're not asking that question anymore. So there are questions like that that we can just get rid of and try to really streamline the process so we can really move through and do the most good for the most. So finally, our new strategies. I talked quite a bit about this. We aren't able to box it in. We hoped we could, but that's when we thought asymptomatic spread was not a major driver of this pandemic, and I don't think that to be true. So we really need people to step up. The prior standards that we were doing, our investigation, our support, and contact tracing just aren't achievable, and so we're putting in some efficiencies and depending on people to follow the isolation orders, even if we don't get to you for a few days because they're there. We're going to work more on messaging and try to get that information out, and instead of one-on-one, working more on multiple, messaging this to multiple people at the same time. Our focus on congregate settings, really where people live. So if you live in a congregate setting, and where you work. Work sites are pretty much all congregate settings. You're there for 8 hours among the same people. They could be more risky, like you're on a line and you're standing side by side with people for 8 hours a day and across from people. It can be, you're quite separate, and then it's less congregate. But those are really going to be our priorities. So really, as I finish up, the spread of this virus is really going to depend on the action of every single person in Stanislaus County. Public health is not going to be able to contain this without people doing what they need to do to stop spread. It's really those staying 6 feet apart from everyone not in your household. It's the wearing the face covering, and of course always the frequent washing of hands, because it's done amazing jobs for stopping disease transmission. If everyone does these things, we can really get our lives back to our new normal. Not quite the old normal, but the new normal. So I think it gets lost sometimes, is there are no safe activities right now. The virus is here, and it's everywhere. And if you think that the things that we've put in place have made it safe, it's made it safer, but it's not. Nothing is zero risk. Everything carries some risk, and people really need to assess everything they do and decide on what their level of risk is, and realize that your level of risk is going to affect all those people around you as well. And so you have to think not just of yourself, but you have to think of others. And if we can really slow this spread, one of the things we're looking really to do is stop premature death, not overwhelm the healthcare system, and minimize the economic damage that we're seeing happening now. I know I keep saying this, but this virus has impacted all aspects of our lives, and it's really dependent on every single person to take those actions that stop spread, so that we can continue to move forward. Thank you.
Thank you very much, Dr. V. So I'm going to wrap up with some discussion on budget, and specifically the recommendations that you have before you today, the request to support some actions. And then we'll go ahead and take public comment and additional questions, because I'm sure many of you have questions related to Dr. V's presentation here. So in switching gears to budget, the California Budget Act of 2020 includes what we call subrecipient CARES Act funding through the Coronavirus Relief Fund totaling $1.3 billion for counties to help pay costs for the COVID-19 pandemic. We are eligible to receive $12.7 million of this statewide amount here in Stanislaus County, and this is in addition to the $96.1 million in coronavirus relief funds that we had received directly from the U.S. Treasury. So these funds must be used in accordance with all previously identified federal rules for timing and purpose, and have these additional state requirements. So we've had substantial discussion on our use of CARES Act funding, and we'll be bringing back some more recommendations for you on their programming at our next board meeting. However, the state budget has now made more available to us to potentially leverage in our community. The state budget also provides $1 billion as a realignment backfill for safety net services that counties administer on behalf of the state. So of this amount, $750 million is provided directly to the state general fund, and $250 million is dependent upon the state receiving additional federal COVID-19 relief, which would be determined by October 15, and that's commonly referred to as some of those state budget triggers. So we have received a schedule of what we think our allotment of the realignment funding would be here in Stanislaus County, and we believe it's about $9.1 million of that $750 million that's coming from the state general fund. About $9.1 million could flow to Stanislaus County. In our agenda item, we had an estimate in there, and I just want to recognize we received these numbers yesterday after the agenda item was posted. So the $9.1 million is our latest number that we have for a projection. Should the federal funding be provided, then we would receive potentially an additional $3 million of the $250 million statewide. So if the federal trigger is positive, then maybe we have another $3 million. So the total funding for realignment backfill in our county ranges between 9.1 and 12.1 million. And what's really important, I want to make sure everyone understands, is that these funds can leverage other federal and state funds, which when applied to eligible services can double the value of the realignment dollars. So while the funding does not flow through realignment sub-accounts, the state budget language specifies this is one-time safety net funding for revenue losses for realigned programs, and shall be used for health and human services programs, entitlement programs, and programs that serve vulnerable populations. So the loss of these funds would be a direct impact to mandated program services. And I want to just be very clear about what are those mandated program services that we're talking about here. We're talking about CalWorks, foster care, child welfare services, adoptions, in-home supportive services, mental health programs, and public health. These services must be provided in our community, and the backfill funds would directly offset exposure to our county general fund. So unlike the coronavirus relief funds, the CARES Act funds, those cannot be used to backfill lost revenues. The state has developed this mechanism to provide significant funding available at the local level to backfill the loss of realignment revenues and help support mandated programs so that we do not have to go to the county general fund. So receipt of both funding streams for use in the 2020 and 2021 fiscal year requires the County Chief Executive Officer to sign certification documents as a condition of receipt of funds that agree Stanislaus County will adhere to federal guidance and the state's stay-at-home requirements and other health requirements as directed by Gubernatorial Executive Order N3320 and any subsequent executive orders or statutes, as well as all California Department of Public Health orders, directives, and guidance in response to the emergency. So it's important that we bring this matter before the Board of Supervisors. So for us to receive these revenues, we have to sign, particularly me, have to sign a declaration that does encumber us as an organization to follow these directives and orders going forward. The governor has made it pretty clear that that they will be using that fiscal tool to ensure that local governments are supportive of their enforcement strategies around the COVID-19 emergency response, and to the point where there are various options being floated, and what I've heard in various news conferences are that they would actually program these funds almost on a monthly basis in some cases. So we might get it for the month of July or the month of August, but our September payment would be contingent upon our continued partnership with the state of California. So I do want to be clear that our enforcement strategy is consistent with the governor's direction from the beginning of this pandemic, and it's based on education, not law enforcement interventions. We have seen conflicting messages regarding the role of law enforcement recently, so we continue to prioritize education for the public and business owners, and we're reserving our law enforcement resources for public safety issues. So this has been a very hot topic, not just in our community, but elsewhere in the state. The governor's made it pretty clear that he did not expect law enforcement to take a lead role in managing enforcement issues around stay-at-home orders and so forth. And obviously there's been a lot of community conversation, particularly with our sheriff and local police chiefs on this issue. We continue to see that it's actually very effective for us to do education. It's very, very rare that we get into a circumstance where just through education and dialogue, we cannot compel some action and cooperation with local businesses in our community. In addition to that, I think most of you have seen the news reports that the state of California has an enforcement task team that has been mobilized. They reported over this last weekend that they visited 6,000 different establishments that have alcohol licenses in the state of California. So they're very serious about their state task force and taking a lead on these particular issues. But there is no question that the state of California will expect our partnership should we get into situations where you have individuals that refuse to comply with some of these particular orders. So we have two recommendations for you today. One was to receive this update from our Stanislaus County Public Health Officer on our emergency and the essential services in Stanislaus County, and we appreciate your time. I know it's a lot more detailed than what we normally do, but we felt it was very important in this instance. And then the specific recommendation I just referred to is to authorize the Chief Executive Officer to sign the certifications for receipt of funds pursuant to California Budget Act 2020, and we must sign those forms by July 10th, or we will jeopardize not receiving the funds that I mentioned from the state of California. And with that said, we will invite public comment and questions from the Board of Supervisors.
Thank you, CEO Hayes. Dr. V and Marianne Lilly, do we have questions or comments from the board? Supervisor DeMartini.
Thank you, Chairwoman Olson. Dr. V, I thought it was a good presentation you had. I had a couple of questions about it because you had stated twice that this was not really a pandemic, a flu pandemic, and it wasn't like other coronaviruses. I don't really doubt your opinion on that. But do you think that this is because this is a laboratory-created virus that makes it so different than what we've seen in the past?
So I haven't seen any evidence that it's created in a lab. I know that that's been going around. I don't know that that's been confirmed. So it looks like the last time, I'm trying to think of how long ago it was, but I mean, coronaviruses are in bats, right? So they circulate in bats. Bats are mammals. And then occasionally they go into some other animals and they can go into humans. So like with MERS, another coronavirus, the other mammal is a camel. With SARS, it was a civet. And with this one, they think it's a pangolin, which is this anteater in China, which they use for wildlife. So I think we have a reasonable animal source that they think it's coming from. So I know there's been a lot of talk about the lab, but I haven't actually seen that to be confirmed. So we can, it's different. So one of the things that I didn't say was like SARS that came out in 2002, 2003, you didn't become infectious until your onset of symptoms. So we started out using that as the model. Well, clearly that didn't help because you're at your peak of infectiousness when your symptoms come. So you've really already been, giving it to people unknowingly for a couple days before. So all viruses are different. It's just acting differently than anything we've seen before, as far as I know. And it just means that everything we thought at the beginning and a lot of things we based our plans on don't really work and aren't true. So that's really all I can say. It's really hard because we thought we knew what we were dealing with and we really had no idea.
Okay, well, as I'd heard it, it came from a lab in communist China, but who knows? There's always some question about when the schools will be able to open, because I've heard, and you're the expert in this, I've just heard this, that children are not affected much by this, and there would not be any real reason not to reopen the schools, for at least for the elementary school children. Do you have any opinion on that?
Yes. I have lots of opinions, and I'll be talking to the school superintendents again next week. If we do not change our trajectories quickly, I told them I can't see full opening the first week of August. So I think we have a lot of talking to do, and again, that's why I keep hammering this, that people have to do their part in slowing down transmission and slowing the spread of this virus, because I think elementary school is easier to open. There's a lot of great data that have come out. The American Academy of Pediatrics just put out a statement that's very good, and then the Resolve to Save Lives put out a real good review of all the literature. Certainly children under 10 seems to do very well with this disease. Most of the severe disease is children over the age of 10. And so elementary school is one of the things that I'm thinking about. But we really need to see how the county looks over the next couple weeks, because it's really going to hang on that.
Yeah, okay. Well, I'd heard the same thing you did, that young children are really not affected by this. So I noticed, too, that, some countries really have done much of anything for this virus, like Sweden and Japan, where other countries like the United States have just allowed this to just wreck the economy and throw millions of people out of work and cost us trillions of dollars. I mean, how can you explain that, Japan and Sweden don't seem to have the high numbers, and they're really not locking people in their homes like they say Norway? That was a good example, really. Norway locked everything down. Sweden didn't do much of anything, and yet their numbers are about the same.
So Sweden has a much higher death rate. I know they've had a lot of deaths over and above. They have the highest death rate of all countries. So they have seen a lot of premature deaths. There are cultural issues that affect spread as well. So Asian countries often, culturally, they don't shake hands, they don't touch. They're a little bit more reserved. They stay further away, except crowded subways maybe. But in general, when you look at the culture, they're a little bit different in culture, which changes the way spread is. So spread is affected by many different things, including the culture, the crowding, and so there are many different ways that countries differ in how it spreads. So, I mean, that's my best explanation. But yeah, Sweden has been pulled out as having the highest death rate of any country in the world.
Okay, and this is the last question I have in the staff report. There was a drug that was mentioned. I've never heard of it before, and I'll try and pronounce it, but I just wondered what it was. It was remdesivir. That's the best I could pronounce it. I've never heard of that before, and I just wondered if you could tell us what that is, what it does.
Yeah, so that's an antiviral, and what it's been shown to do is decrease symptoms and hospital stay, I think, from like 15 days to 11. So it's, first of all, about the only treatment we have. Now there's the dexamethasone, which is a high-dose steroid that seems to prevent some lung damage. So, but the remdesivir was the first one, is still really the first medication as an antiviral. And we were getting, Gilead donated their study supply to the United States, and we've been distributing it out to the hospitals. We distributed the last of it last Thursday. And we do not know when more is coming. Because this is a new medication that hadn't been FDA approved before, they didn't have a supply chain going, and so they're working to get a supply chain up and supply of this drug out to people. But we have been getting it, we have been distributing it. I think we had 5 different shipments that we allocated out to our hospitals. I think it's probably pretty much gone already because our hospitals have such high census. So we're waiting for more. The U.S. government did purchase more, but we have not gotten details on how it's coming out.
I see. Okay, thank you very much, Doctor.
Other questions, comments from supervisors? Supervisor Berryhill, do you? Yes, Supervisor Berryhill.
Madam Chair, can you hear me?
Yes, we can.
Okay, it seems to me we're all concerned that we're doing so well. And the parents disagree. It was just so bad. And really to get a little complacent. And it was no bad. No reason why we can't. Yeah.
Supervisor Berryhill, the audio isn't quite as clear today. Would you mind texting or emailing me your comment and question, and then I'll repeat it here in the chambers?
Yeah.
Thank you. Other comments or questions from supervisors before we go out for public comment? Okay, I have some, but we'll wait for after public comment. Is there any member of the public in the chambers wishing to offer comment on this item? Seeing none, County Clerk Liz King, do we have any email comments that have been submitted on this item?
We do not.
Okay, thank you.
Well, other than the one you have already, sorry.
Yes, thank you. I will bring it back to the dais, and just to indicate which ones we do have so that we know they're received. On this particular item, we do have comments from Gary Fawcett. Gary, we will be back in touch with you on your item. We have them from Brooke Reed, from No Paramo, from the California Rural Legal Assistance Foundation, as well as from Mike Garcia. So your comments on COVID-19 have been received and will be responded to. Thank you. So bringing it back to the Board of Supervisors for additional comments and questions. Supervisor Withrow.
Okay, I'll go. First, Julie, thank you very much, and Mary Ann, thank you guys, Ryan, for all your work, and everybody out there at the EOC and the contact tracing that's going on out there, and just everybody working around the clock. And I know everybody, it's back to 3 days a week here now at the EOC for the meetings, and I know it's consuming everybody, and I can't thank everybody enough. Our chairman, who's had to be at those meetings, I've started to sit in on them. I appreciate you letting me sit in on some of these recently. And it's just an unbelievable effort by everybody, and very much appreciate, and Jody and everybody who's having to work through all these things. So, and business does continue to go on in the county besides COVID, so it's not like this is all that we have to do all day. We had a full plate to begin with. And so I just can't thank everybody enough at the county and all the work that they're doing. So just a couple of quick comments really with regard to, we go through all these stats and the data and everything and our models, and we're trying to figure this out daily, hourly almost, to figure out where we stand. And bottom line to me, my little simple mind here, is that as we continue the cases, the cases are going to continue to be what they are. Like you said, it's unable to box this in. And I agree with that. I think that train's left the station. I think this thing is going to run its course. And I don't know that there's much we can do about that. What we need to do is try to save lives. And the way we do that is to be able to protect people that, at least that have the symptoms and end up in the hospital. We need to make sure we have capacities in the hospital. So that's the way that I look at this, is to make sure that people aren't dying and that we are able to have the capacity in our hospitals. And obviously we've had a pretty good increase over the last, if you look back to the last month, a little over a month, we've gone from 129 hospitalized to, as of yesterday, 213. Though there is positive, yesterday it was 213, the day before it was 222. So let's find something good there. So, but again, a jump in hospitalizations, and luckily deaths, we haven't had a major in that same period of time from, June 28th through 7/6, we've had 4 more deaths, which again, miserable, terrible, heart-wrenching for everyone involved. But when we're just looking at numbers, actually, as we've talked about, the death rate is going down on this, which is great. We were at June 1 at 3.9, and as of yesterday, 1.6%, which again, I'm not trying to minimize that, but we've just got to balance all these things. And the other thing that we look at here is that Julie, you said level of risk, and I know that's what we have to do is weigh the level of risk, but not only for COVID patients, but for non-COVID patients. And I think it's very telling as we look at the hospitalizations and see this increase in hospitalizations and our concerns start to become more and more about hospital capacity, that we find out in this information that it's not only COVID patients that are filling up our hospitals. We've got a large surge in non-COVID patients going into our hospitals, which leads us back to the conclusion, or you can take all kinds of ways to look at this, but it's pretty obvious in the conversations I've had with physicians and that there are people that are not treating things that should be treated as a result of their fear of going to a doctor or going to the hospital. And so what's happening now is we have people that are waiting until things become acute and end up in our emergency room and end up dying because they are not treating their symptoms that in the past would have just been easily treated and prevented. Deaths would have been prevented. So when we talk about level of risk from this whole thing, the whole adventure we've been going through with COVID, we have people dying from the virus, we have people dying because of the conditions they're in and not being able to get treatment that they normally would have prior to the virus. So again, level of risk both for COVID and non-COVID patients. We've got to weigh those and find that balance, like we always talk about balance. So where we are right now, I see that we're getting better information. It's hard to with the hospitals. We've had some great conversations trying to figure out what really our capacity is. We know we've got all kinds of plans in place to deal with if this continues to increase and the capacity becomes even worse. We've got other options. The hospitals have other options. We're doing everything we can, again, to try to keep people alive if they end up in our hospitals and make sure they have a place to recover. So that's all great. Doing what we can, and we'll just keep doing that. We're about a week into this most recent kind of clawback from the governor as far as what we can and can't have open, and this is supposed to be a 3-week period. Let's see how things go over the next couple of weeks as far as our hospitalizations, and we'll see where that goes. And I'm fine with that. Let's get through the next couple of weeks and see where we are before we make any more decisions. With regard to this most recent thing, Jody, that you have to sign here, I just really have some concerns about this and just kind of the language in this. If we look through this, in order to get this money, we have to sign this and agree to these things. And as I look in here, and Tom, this is maybe even a question for you to tell me how we can do this. When I look at item or number 4, paragraph A, in this certification that Jody has to sign, the CEO has to sign with regard to this, it talks about that we have to adhere the stay-at-home requirement and all other health requirements as directed in gubernatorial executive order, which is fine. That's the order we've all been living under. I'm perfect with that. But then it goes on to say that we're going to guarantee here that any subsequent executive order or statutes and all California directives and guidance, and so any subsequent executive orders, how do we sign something? I'm just thinking about my business, my clients, things that we deal with. How do you sign something that you don't even know and agree to something that's so ambiguous, that talks about this applies to your current executive order, which is easy. That's easy for us to do. But this is going to apply to anything else that comes along the road that we decide we want it to apply to. And you need to sign today and be held accountable to that for something that's that ambiguous. Tom, can you tell me how that works, how we can bound our residents?
Well, am I on? Well, I think what the governor is, and the governor's office is looking for is to make sure that as we go forward, that the counties are cooperating with the governor's office and with the state public health officer. it is an issue of concern that we don't know what those orders are going to be, and that, you know, we're being asked right now, hey, comply with everything I say in the future. But that is, I make that statement in light of also knowing that under statute that we're required to, in any case, comply with the directives of the public health officer as they issue them. So it's not really asking anything other than what is already required by statute.
So you're saying, that but if we sign this and agree to accept these funds, because that's what it all comes down to, it's the money, and I guess I'm not so concerned about the 12 million, what is it, 12.7 million, is that what that number is? That's being dangled in front of us right now to make sure that we stay in line with the governor. It's concerning that there's a threat to take away our realignment fund, and that's just an insult to me, I guess, to some extent, that you know, if you don't do this, we're actually going to hurt these other people too because of you guys. I guess I have a real hard time with that. I could see new funds that they want to give to us, and we've got to fall in line here, but then to threaten to take away other things if we're not, which hurts other people in our community, and I guess they would blame that on us because we didn't agree to do everything that potentially he could come up with later down the road. So I guess that's where where we are right now. I'm fine. I appreciate everything that we're doing, and I think we're doing everything we can with regard to hospitalizations and all that kind of stuff. But then when something like this comes through, and we're asked to agree to something that some sort of unforeseen contingencies, I don't know how that can even be enforceable for us to have to sign this. I mean, I'm fine with us just taking these funds that come in and just putting them aside and wait and see what happens. If we're going to get the $12 million, we sign this and just put this money away and don't touch it under the fear that we could have to return it to him if at some point we don't agree with something the governor wants this county to do. So those are my concerns right now with looking at everything else, where we are, hospitalizations, all the things we're doing. Let's go another couple of weeks and let's see where we are, and let's come back here again and we'll talk some more about that stuff. But just this document and the requirements of us to commit, ourselves as supervisors here, which means we're going to commit our residents to things that we don't even know what this governor might come up with next, and to say that we have to abide by those. And like I said, maybe there's a way we can put the money set somewhere so in case something like that does happen that we haven't touched it, we'll give it back to you. Anyway, I'm just throwing that out there for us to discuss. So.
Thank you, Supervisor. Before we move on to Supervisor Chiesa and myself, I do have Supervisor Berryhill's comments and questions. So I'll just read his text if that's okay. Supervisor Berryhill is asking, did we just get complacent? We need to wear masks, stay 6 feet apart, and wash our hands more. If we do begin to do those things in better numbers, can we expect our numbers to come down quickly? So that's his first question.
I think that's a really hard question. So I think that is going to really slow spread. I mean, if I get it and I'm wearing my face covering the whole time and I'm staying 6 feet apart from everyone, I shouldn't be spread it to anyone, so it should stop with me. So I think we can turn it pretty quickly. The problem with hospitalizations is the numbers lag a week. So if we're looking at case numbers, I think we can get a decrease. If we're looking at hospitalizations, because they lag a week, and because people stay for usually at least a week, up to 10 days, 13 days if they're in the ICU, they're going to continue to get patients and continue to get fuller for weeks. And so those numbers are more of a problem. But I think we can see in cases pretty quickly some decreased spread. I mean, it'll take us a week or so because, the 14-day, up to 14-day incubation. So yes, I think we can. And it's really pretty simple. If we want to go back and eat in restaurants, this is what we have to do everywhere. Yeah.
Okay, thank you. And then the second question and comment from Supervisor Berryhill is, when can we expect businesses like nail salons and restaurants to reopen? It has been 4 months for nail salons since they have been able to go to work.
Yeah, I know, and it's hard. What I'm hoping is that we see
we see a trend in the right direction. So we know for restaurants, we have to wait 21 days. For all those things we just ordered, there's 21 days, of which we're through about 6 of them, I believe. Today is day 6, because we did this on Wednesday. So we got 15 more days to go, and we need to see a better trend. I have a real hard time opening up any sectors when our numbers are looking so bad. So I think nail salons, I think these personal services aren't real high risk, and I think we can open them up when we start seeing improvements in here with some modifications, with all the required modifications, I should say, from the state guidance. And then I think when we first open them up, an additional requirement will be that no services can be offered that requires the removal of a face covering, because I don't see any way to make that safe right now when we have so much infection going around. But other than that, I think we would be able to get most of those open in the next couple weeks. I'm hoping we see changes in trends, and then I'm hoping we can get those open, because they have been closed for a long time. And I don't think they're real high risk. Everything's a risk. I don't think they're real high risk.
Thank you, Dr.
If I could just clarify, and I think echo some of those comments, our openings have largely tracked the trajectory from the state of California. That's basically what we've precisely tracked them on, which had prioritized some other openings ahead of personal services. So we followed that trajectory, and then by the time personal services were available, we had already seen these concerning numbers emerging from our community, which we put the brakes on at that point. However, I do want to recognize with Dr. V's comments that some of those personal services can definitely be shown to not have as much risk as some other businesses in our community that had an opportunity to open up, maybe closed now, but previously opened up. And I just want to acknowledge that for some people it flunks the logic test of how did one thing open up and they didn't, and compare that to some of our opinions here. So I just want to acknowledge that, and to point out, for those who don't follow the process closely, we did follow along the state of California's path on this. Not every county did, but in retrospect, we've identified some things we could do differently, and when the opportunity presents itself, we'll make those changes.
Thank you. Supervisor Chiesa, any comments?
Yeah. So first of all, Dr. V, I have to thank you, and Marianne, I've said it before, it's very lonely at the top. You're making decisions that affect a lot of people, and there's a lot of weight on your shoulders, and I want to tell you I very much appreciate all the thought that goes into the team concept of making decisions. It's not made in a vacuum. It's a very collaborative process, and to the team, to our chairwoman, to Jody, Office of Emergency Services, Mr. Murdoch, the list goes on and on. So I know that you know, but I want everyone to know I'm very supportive of the process and of the decisions you've made. I think, going back, our CEO had said something about underperforming or overperforming the number. It just depends on how you state it. I've always stated it the other way. We underperformed the lines to the expectation, the modeling, and I think people got complacent because we did so well early on when we were at shelter in place. And then we open up the economy, and it turns into more back to normal, and we can track that through the social distancing model. And now we have an issue. The positivity rate kept going up, and it's hard for a lot of people to understand the positivity rate. I posted maybe about 10 days ago, I think it was on the 26th, and I used a couple of the state modeling on deaths. I used our hospitalization, the social distancing model, and it turns into, as you try and provide information, it changes so quickly. It is just I can only think of bad words right now to say. That's why I'm trying to come up with the right word. But it's disarray on social media because it's very complicated. But the bottom line on positivity is it's like a multiplier effect, right? If 100 people, and we had a 5% positivity rate back then, 2 months ago, 5 people would get it out of 100. Now we're at 13%, so 13 on the same 100 tests. And that's the alarming part for me personally. This is like, you've been able to see this for 10 days or 2 weeks now as the positivity rate kept going up. And that's, so things change quickly, and it makes it look like we are talking in circles all the time. that our information isn't good, but the bottom line is we talked about spread and how it spread. As we continue to learn, some things we could have done differently, but hindsight's 20/20. And as they always say, when was the right time to plant a tree? The best answer was 20 years ago, right? So you have this beautiful tree with shade, but what's the next best day? And that's today. Don't wait until tomorrow, do it today. And so as we talk about wearing masks, I tell people you got to wear a mask. You have to try and do your part, social distancing. We can't stop the virus. We've never said we were going to stop the virus. What we're going to do is bend the curve, which is the hospitalization. It's tough talking with a mask on. That's why I keep taking it off. It slides down. But and so we have to bend the curve because it comes back to just what Supervisor Withrow said. It's about not overwhelming. And now that we see that we're headed towards a potential overwhelming situation, it becomes more critical for the public because there's not things that we're going to do other than shutting the economy down even further that would possibly stop that. So it's up to the public, and the public is going to determine whether we have to step back or whether the governor forces us to step back further in the economy. And I don't think there's anyone in Stanislaus County that wants that if possible. As far as the monies available, nobody likes the governor dangling the carrot over our heads, but I can just tell you the realignment component when we talk about what programs are affected in 91 realignment, 2011 realignment, adult protective services, child protective services, the CCP money that is used on for recidivism, all the programming in our jails, everything that we just have adopted and we're completely for. The mental health, we know we're short on mental health monies, and a big shot of both 91 and 2011 realignment go towards mental health services, and we've got issues there, and this money would be critical since it's matched, almost doubling that component. The $9 to $12 million will be $20 million for our community, and those are services we would provide. So it was a brilliant move or a bad move, depending on what side you are, but it's a move that I can't not accept. And the CARES Act money, the $12 million, if nothing else, that money could end up in business in our community, directly related, like we're doing the $15 million. We haven't come out with the program, but investing in small businesses to try and help them through this COVID era, to try and keep more people in business. So I don't love it, but it's money that we need in this community to provide services for those that are the most vulnerable. So with that, again, I'm going to recommend, obviously, you sign the paper, and I'm going to vote for it. But people, if I pleaded before to wear masks, to do your part, it's more important today because everything has changed from even when I posted that on social media back on the 26th till today. It hasn't gotten better. It's done just the opposite. It's gotten worse.
Thank you, Supervisor. And before my comments or questions, I do have one more question from Supervisor Berryhill, which is probably most appropriate for the CEO. He's asking, some counties are considering fining people for not wearing masks. That's not something that we are even considering in Stanislaus County, or is it?
No, that has not been a strategy that we've looked to employ whatsoever. I am aware that at least in one city temporarily, they had passed a local resolution to provide for that potential, but then that was removed. And I'm going to look to County Council to see if I'm missing anything, even if there were something in the code that allowed for that type of a fine. We're not pursuing it, but I'm going to look to County Council for confirmation.
Yeah, in order to fine individuals other than what the misdemeanors that are already available, in order to fine individuals for not wearing their mask or not complying with the mask order, I think that would require the board to adopt an ordinance that would make that an infraction, because currently we don't have anything that would allow violations of the order to be charged as an infraction. And so I think that if there was any desire to do something like that, we would have to do an ordinance first.
Okay. Thank you, County Council Bose. Supervisor DeMartini.
Yes, thank you, Chairwoman Olson. I just had a comment on what Supervisor Withrow had said. I saw this 4A also, and I had the same kind of heartburn about this additional orders that might come down the pike, who knows when. And I think we're taking a risk in the voting for this, but, we have seen around the country that certain governors, act like emperors. And like Wisconsin governor forbid people from buying paint or vegetable seeds. And I mean, it just sometimes it's ridiculous. So it's I don't know what else could be coming from the governor here. But if it's something really unreasonable, it comes down the pike later. Like having the sheriff's department ticket people that are sitting on a park bench or something like that's happened in other parts of the country. I'm going to have a real problem with that. So I think that was a good comment, Mr. Withrow, and I think we have to watch this thing so any future edicts from the governor are reasonable and make some sense, not arbitrary and just not based on any kind of science or anything. Especially, the stay-at-home order is problematic enough because we know that being outside you're better off than inside, and I just don't want to see people's lives being arbitrarily restricted in the future when it doesn't make any sense to do so. So there is a little bit of risk in this, but I mean, if there's something unreasonable comes down the pike, we may have to take another look at this. I mean, I don't see it so far, but it could happen, and it's happened in other states.
Thank you, Supervisor. I have several comments and a few questions as well, so I'll try to take them one step at a time. I want to start with a thank you, as I often do, for Dr. V, Marianne, everybody who's working in public health, County Council, CEO, everybody at the Office of Emergency Services, the Sheriff's Department. This has been an all-hands-on-deck effort for a lot longer than I think any of us originally anticipated. And the last couple of weeks in particular have, I think, been particularly difficult as we learn new information that is sometimes confusing or troublesome and readjust. I appreciate you talking, Dr. V, about how much we know differently today than we knew in January and February. And I think it's good to remind ourselves that that's what science is. Science is not a clear point in time that is a fixed fact that never changes. Science is about testing hypotheses, testing theories, and then reevaluating decisions and conclusions based on the results of those tests. And I think I've never seen that illustrated to a greater degree than in the last 4 to 6 months with COVID-19. And while having the recommendations, whether it's from the CDC or the county or the state or the feds, whether those changing recommendations are frustrating to people or confusing to people, there's no question that they are, but that doesn't mean they don't lack credibility. That's all about testing a theory, testing a hypothesis, gaining new information, and adjusting accordingly. And that's what everyone, I think, is trying their best to do, knowing that it may have to change again as we continue to learn new information with the extent of the virus being here. So a few particular questions that I have. One is on, and I don't believe it was part of the recommendations, but it was part of the presentation as it relates to education and enforcement of various orders. And my question for County Council, but before you answer it, I want to explain my opinion on the issue. But my question for County Council is whether we need to take board action to perhaps modify previous board action, because I know previous board action was that the county shall not use resources to enforce anything related to the state order. I know our intent in taking that action was consistent with what Governor Newsom has said all along, that he didn't expect this to be a law enforcement response. He expected this to be, I forget the exact term, but community pressure, self-policing, et cetera. But if we are seeing instances now where we either need to educate or enforce certain elements of local or state orders, I do wonder if we need to revisit that board action. And in particular, what I would support is enforcement against businesses who are blatantly defying opening guidelines. And the reason I say that is because the vast majority of businesses in various sectors are working really hard and spending a significant amount of money coming into compliance. I think of restaurants in particular. And it is unfair to those establishments to have a handful of businesses within the same sector who literally aren't complying with any of it. And so I think that's appropriate for an education response at first, clearly. But if education proves to be insufficient, I think there may be cases where enforcement is appropriate, again, out of respect for those businesses within the same sector that are in compliance. So that would be my question for County Council, is if we need to provide any direction or formal action in order to change our current practices.
I think that's a good question, and it's good that you pointed it out. I think it's something that we would probably need to come back to you on, but off the top of my head, I think that because of the certification that you're authorizing the CEO to make, that there is a certain extent of overriding your previous order, in that now you are authorizing the CEO to comply with and to enforce, I forget exactly the terms of the certification, but to enforce the directives of the governor's office. And so I think to a certain extent that you are overriding your previous order or directive, but I think it does require some additional thought, and we can come back to you on next Tuesday and with a recommendation.
Sure.
Thank you very much, County Council. I also want to acknowledge that in the prior action of the Board of Supervisors, you did grant us the authority to take enforcement action on mass gatherings in the community. And there have been a couple different definitions out there in terms of, well, what might be a mass gathering. We've been very conservative in even exercising any of that kind of authority. And I'll just reiterate for the board and members of the public, our desire is purely for education and to try to get businesses on board. I think the point that you bring forward, Chairwoman Olson, is a very, very good point, which is for those businesses that are investing in the process to comply, they shouldn't be at a disadvantage based on other businesses that are not. With that said, I would agree with County Council. We can come back and have a broader discussion with this, with the Board of Supervisors on this. I will tell you, we do not have an interest in seeking just blanket enforcement authority to go out and to be heavy-handed in this community. That's not going to be the path that we need as a community for sure. And it will be in very isolated circumstances where we need to really exert any specific local authority. I will tell you that I expect that the combination of authorities that the state has put together with their own task force for enforcement will most likely be the most effective tool for working with even local businesses. There are very few local businesses that in some way or another will not fall under the umbrella of one of those state enforcement agencies that they have put together, and they're very, very active right now. So I just point that out as that's also out there and available, and regardless of actions today, we're focused on education, and it's been successful for us.
Okay, thank you both.
So if I could, sorry, just really quick, just to expand on it a little bit. So regardless of what's going to happen here with this, just with regard to, it would be great if we could, just like in any nuisance abatement situation, if we could, I really think the board needs to weigh in to some extent. If we find that something like that's going on and we're about to go out and do something, shut something down, I think it's something that we need to, and like you said, it's probably few and far between that's going to happen, so it's not like it's going to overwhelm us. But I think to the extent that does, I just think the board should be a part of that decision before we before we do something like that. So I don't think that would be that hard to do, right? For us to, if we see something going on, we could talk about it at the next meeting before we actually do some action.
So I immediately want to think through all of the different scenarios that could occur in the community, as long as that request does not, I think, take away from the prior understanding regarding mass gatherings. I think we could feel pretty comfortable with something like that. But for example, if someone tried to put on a large community event and, unpermitted in the local community, and we were trying to take our actions, and we wouldn't want to have to pull together an emergency meeting of the Board of Supervisors because somebody in the community was acting outlandishly.
Sure, just an email, maybe to everybody, a blind copied email.
Oh,
or something like
that part's easy. Notification to the board is very
Yeah.
simple. I think putting the question in the hands of the board as to whether to or not to is a different matter.
No, I don't expect us to micromanage everything, of course, but just an email that this is going down so we find out about it ahead of time and everybody has a chance to express their concerns would be great. Yeah.
Yes. Hey, we hear you loud and clear, and we will certainly do that.
Thank you. So moving to the certification, I share my colleague's concern about it referencing any subsequent executive orders. I think the intent there is probably sound, but I don't like to rely on intent when it comes to signing things. So I would also suggest that unless we have some absolute need to spend the money, I'd rather put it aside to see if an instant comes where we just can't support a future order that is of significant concern to me, that we would be signing to agree to something that we don't even know what it is. And then my other question is there an end date? I don't see an end date, but could this be an executive order that he passes 3 years from now? Or that he signs 3 years from now?
I think it only relates as to the emergency, the COVID emergency, and so his orders with regard to this emergency will expire when he issues an order that says that the emergency is done. So as far as this certification, that's how I'm looking at it as far as its length of or its lifetime, its lifespan. With respect to setting it aside, I'm not exactly sure what your comments are with respect to that.
I'll field that one. So there would be no harm or challenge to us from a budget perspective in regards to the $12.7 million in CARES Act funding to essentially add that as another component of our CARES Act reserve for us to reconsider in the months of August and September when we decide to move forward. By then, we will have implemented another round of our small business relief program in Stanislaus County, and we may decide that we could use some of those funds to further enhance that program, as Supervisor Chiesa suggested as an option earlier today. However, the funding that is available for the backfill of realignment, that would be very problematic for us to reserve, and I'll share with you why. These are not funds that we currently have. Realignment programs are directly tied to sales tax, and it is the reduction of sales tax which has created the significant hole in the budgets of these mandated service programs. When realignment was first envisioned, it was not contemplated that there would be such a significant one-time event that could impact it like it has. So at this point, the state of California holds the cards. If we just play out the law as realignment exists, our budget will have significant holes in it, and the county general fund will have to backfill those holes. So with respect to realignment, the state is saying, here is some money that we will take out of the state general fund, and we will give it to counties to help you with your hole. And in exchange for that, we are requesting the cooperation, or however you want to characterize what we're signing here today. So those funds are intended to be placed into the county budget. We were hopeful that the state would make a move with backfill of realignment funding. This was the number one issue we were watching with the state budget. We obviously were not tracking or requesting these strings attached to it, but this was the number one issue that we were looking for. And for us to reserve those funds means that when we bring our final budget to you in September, which we're currently building right now, we would have to tell those departments to assume they will not receive those funds and to bring forward all the reductions that would come along with them.
And
Okay,
Julie,
I guess-
I'm sorry. I think it's important also to note that that the certification has to be signed by the 10th of July.
Yeah, thank you.
Yes. Yeah, I'm comfortable, as my colleagues are, with us moving forward with signing the certification. I do want us, though, to keep a very close eye on it because, again, as Supervisor DiMartini said, I think there's a very, very small chance that an executive order would be signed in the future that we wouldn't comply with. But there is a very small chance, and I can imagine a scenario where such an order might include something that would make losing $9 million look inconsequential to what's being asked. So as long as we just keep an eye on it, I'm comfortable moving forward with the certification. And then lastly, I'm not asking for a response here because I don't think it would be fair for me to ask for one immediately, but I am growing in concern about the status of our economy and the impact that that is having on individuals' lives, on small businesses in our community, and the spillover impacts of that on cities, on counties, on individuals, on families, et cetera. And that is not to diminish the severity or reality of COVID-19. Just this morning, I learned of the death of someone that several of us know quite well. At least according to his son, he passed away from COVID this week. So there's no question this is real. There's no question we have a responsibility to slow the spread, to make sure our healthcare systems aren't overwhelmed. But based on the information we're receiving and heard today, the fact that we're learning now, it doesn't appear that there are going to be waves to the virus. It doesn't appear we're going to be able to box this in. The goal never was to stop the virus, as Supervisor Chiesa said. I think we need to begin thinking about and planning for what an open economy and an open school system looks like in the midst of the coronavirus. We just simply can't be shut down for months on end. We just can't do it. And I am concerned that it seems that some decisions are being made, most of which is in the state's hands. Some are within local county hands, but most of which is in the state's hands, that aren't really based on slowing spread where we're seeing community spread. They're based on just keeping things closed or closing things again because we're concerned about our rising numbers. And so I just had to put it out there that I'm growing and concerned about this. I think it is time, I think it's past time to open personal services. I haven't seen anything to suggest that spread is happening there in other counties where they're open. But I think it's something we need to really spend a lot of time thinking about, planning for, because if this is not going away or slowing anytime soon as we prepare for another wave, if this is sort of the new abnormal, to quote a phrase from former Governor Jerry Brown, we got to figure out how to live better within the new abnormal. And with that, I think we're ready for a motion.
You know, I just want to make sure, so if we're going to get to a motion here, what we're motioning for. So we talked about putting aside the 12.7, that we're not going to touch that in case, you know, something does come up. And we're used to receiving money with strings attached. That's what we do. That's constantly, unfortunately, whether it's federal money or state money, we have strings attached. I don't think we're used to receiving money when we don't know what the strings are and they could be pulled at any point and then have to, you know, abide by those or else lose these funds. I get it with the realignment money. I know we were depending on it. We need that. I get that. We have to have that money. But like I said, I just can't believe, I mean, we're talking about trying to help the health of our community. And I think nobody knows our community better than us who live here in our community. And to have to turn that over to our governor and let him decide what's best for our community, or else he's going to take money from us that will then make our community even less healthy, whether it's through our mental health system, our health service agency. You know, it just, it's just appalling that we're in this spot. And there's nothing we can do about it right now. I get it. I'm just going to vent here a little bit. This just blows me away that we are in this position. And just as Kristen, as you're saying, how long is this going to go on? The cases are going to continue. We're not going to be able to stop that. What we need to do is help prevent deaths, and we're doing everything we can. All our hospitals are doing all that. That's great. But to continue to be in positions where we have to agree to whatever one person who doesn't even live here decides is best for our community is just it's just tough to stomach for all of us. I know, and we're all doing what we can here. So I'm going to begrudgingly. This is one of those ones where Jim says I'll hold my nose and vote for this thing, and that's I feel what it is. The 12.7 million, we'll let that sit if that's what we all agree to here as part of this motion. That we'll go ahead and agree to have Jody sign this with the 12.7 we don't touch to make sure nothing else happens, and then just whatever. Again, my statement that the governor to even tell us that we have to do the rest, or else he is willing to harm our county even more if we won't go along with what he thinks is best for our county. Very disappointing is probably a good one. It's my parents used to say, I'm disappointed, and it is very disappointing. So anyway, I'll go ahead and make the motion if that's what it takes. That we're putting the motion is that Jody go ahead and sign this, unless anybody else has some other comments. I don't want to.
I do have another comment. So we can put the money in reserves because we're not spending it anyways. We've got 30 million in reserves, and then we'll have 42 million or 45 million, whatever that number is. But it can't be into perpetuity because the money has to be spent by the end of the year. This could go far beyond. So doing a non-time sensitive and renew it doesn't make any sense to me. And we all have to remember that all 58 counties are going to, well, I think they're all going to sign it, but CSAC is going to make sure there's nothing that's any more onerous than, because we're abiding now by a matrix that is set by someone else. If we don't meet the matrix, we get shut down. So there is a part of us that needs to do better. Some of this is on us in order to get the money released. I don't mind putting it in reserves because we don't have any plans for it today, but saying that we're going to leave it in reserves until something, because the way the money is coming out on realignment, which is under the same guise, is that they're going to give it to us monthly. So at some point, if we make a determination that it's out of bounds, something's out of bounds, or we won't abide by it, then we potentially lose that money. I agree, this is a terrible way to do business, but from a standpoint, but I can understand why he's doing it. If I was if we think that Dr. V's in a lonely spot, he's in a lonelier spot. And again, I don't agree with him, but he's making broad brush decisions because he can't come in and say, well, you need to wear a mask in Stanislaus County and you can open the economy. So he's got a broad brush to some degree, and that's what the matrix are for. So if we say we're going to put it in reserve, this can't be a perpetuity, because we have to make a plan to spend the money to get it in the economy, whether that's maybe there's costs, maybe there's outreach, maybe there's another business program. So let's not do an open-ended stays in reserve, if that's...
I'm fine with that, and I think it has to be spent by a certain date anyway. I think we're on the agreement.
Say a couple of months, and then we'll bring it back to this board, and then we have to extend it, or...
Yeah, that's fine. Yeah, that's...
And I think if county council could weigh in, am I correct that if the worst case scenario takes place, which I don't believe any of us expect, but if it does, where an executive order comes down the pipe that we just can't support as a board, and we've already spent the money, then there's always the litigation route if it has to be as an option. Is that correct?
Yeah, there's always the option to litigate. I think we would have to make a determination that the order was illegal. We can't just say, we just don't like it.
We didn't like it, yeah.
We disagree with his policy choice. We have to find a way, an argument that makes the statement that his order was illegal true. So
Okay.
That's where we're at.
Thank you.
And I just want to add one more thing. Throughout this entire state budget process and the deliberation of the state budget, the negotiations that went on, there was discussion about the need for counties to potentially put forward plans to the state to tell them how we were going to spend our $12.7 million. And the reason, and it makes sense, is they want to know it gets spent before December 30 when they expire. So I just want to put that out there so that if you see us come back a few weeks from now or so, earlier than expected, to say we need to put together a plan for these funds, it will be for that purpose. So I can't advise you today on exactly where the state landed on those requirements. A lot of it has been in flux, but I know it was a topic of conversation, and it may require us to act a little earlier than originally planned.
Okay. Other comments or questions from the board or a motion?
So I guess that we'll go with that motion that we will not immediately spend the funds, the $12.7 million, to go ahead and instruct Jody to sign this, and we'll hold off on spending that money, come back with a plan as to how we think we spend it, and then it will be a time, there will be a date that we'll have to spend it by. I realize that, we all realize that, but and let's see what happens in the meantime. And, yeah, so that's my motion.
I'm concerned about the...
Thank you, Supervisor Berryhill.
I'm concerned about the time period for the 12.7. Do we need to have a date certain, or are we okay with the way it is, Jody?
I'm okay with that broad suggestion, because I know that we will come back to you at the time that we feel is appropriate. The only clarification that I would request is that the board recognize that we are going to program the realignment funds into our budget. And that, of course, should the board later to decide that they do not want to receive those funds from the state of California, you can always undo it through the Act of General Fund Support. But it is our intent to program realignment funds into the county budget that's going to come to you in September.
So we have a motion by Supervisor Withrow and a second by Supervisor Berryhill.
Yes. And with that, County Clerk, will you please call the roll?
District 2 Supervisor, Supervisor Chiesa.
Aye.
District 3 Supervisor Withrow.
Aye.
District 4 Supervisor Berryhill.
Aye.
District 5 Supervisor DeMartini.
Aye.
And District 1 Supervisor Chairwoman Olson.
Aye. Motion passes. And with that, we will adjourn in a moment for closed session. But first, County Counsel Tom Potos, can you speak to closed session?
Yes. I lost it. Things are moving fast.
Yes, they are. Sorry.
Yes, we have closed session this morning. Conference with Director of Emergency Services, threat to public services pursuant to Government Code Section 54957, Subdivision A. The board will confer with the Director of Emergency Services and County Council regarding matters posing a threat to essential public services and the public's right of access to public services or facilities. And with that, it'd be appropriate to open it up for public comment.
County Clerk, do we have any public comment on this closed session item by email?
We do not.
Okay. Is there any person in attendance wishing to comment on closed session? Okay. And with that, before we close the meeting, I will say to the person who just submitted an email question related to COVID-19, we will certainly respond. Thank you. And with that, this meeting is adjourned to closed session.